Welcome to the AT Parenting Survival Podcast, where you get help and guidance through the chaos of parenting a child with anxiety or OCD. This show is for educational purposes and is not intended to replace the guidance of a qualified professional. Here's your host, child therapist, Natasha Daniels.
Well, hello there, and welcome to another episode of the AT Parenting Survival Podcast. Today, I want to break down anything that might be a little confusing for you. And so some of this might seem really simplistic. We're going to talk about who can help you with your child's OCD. We're going to start off really basic, but stick with us because then we're going to get into some areas that you maybe are not aware of, like the different levels of care and what they mean. There are low level and then there are high levels of care. And that often is Greek to parents. And it's really helpful for you to have the big picture of what does treatment look like and what are treatment options depending on how bad this gets. And it's good to know your options ahead of time so that you understand the language that therapists might be using and saying to you. Because a lot of times I think as professionals, we say things and we forget that parents don't understand these acronyms and they don't understand what we're talking about. So I'm going to start off very basic and then we're going to get kind of complicated. But before we jump in, I do want to thank NoCD for sponsoring this episode. And NoCD offers affordable, effective, convenient therapy, and they're available in the US and outside the US. And you can schedule your free 15-minute consultation to see if NoCD is the right fit for you and your child. Just go to treatmyocd.com. That's treatmyocd.com. I'll leave a link in the show notes. And I will say that NoCD makes my life a lot easier because since NoCD has provided counseling and therapy for OCD in all 50 states and globally, my job has gotten easier because I know that NoCD therapists are trained and they're getting the supervision and consultation that I know is high quality. And so that gives me peace of mind that I know that they are at least going to be doing the right approaches and have the right supervision to be effective. So that is going to play into what we're going to be talking about today, because the first question that we're going to talk about is, how do you find the right help for your child with OCD? We'll start with that, and then we're going to move into like different levels of care. So I think it's important for you to know, in case you don't know already, and some of you who've been around for a while already know this, but hang on. Any therapist can treat OCD. They can say they treat OCD. Let me clarify. Any therapist can treat OCD legally, and they can say they treat OCD, and there's no consequence for that. However, most therapists are not given any extra training on OCD. This is improving. There are a couple of programs in the country, in the United States, that are fantastic, and they're giving really good, high-quality OCD training, but that is the exception, not the rule. My graduate program didn't touch OCD at all. Most graduate programs are not touching OCD. It's a mention. It's the DSM criteria for OCD, and that is it. You're not getting in-depth training on how to assess, spot, and treat OCD. Most people who graduate have never heard of ERP, which is exposure response prevention, the go-to therapeutic treatment for OCD. It's not taught in most graduate programs. Scary, yes. And so the question isn't, what degree do I need to look at to get the highest quality treatment for my child with OCD? That's not the question. The question is, what person do I need to find that has had the extra training and the desire to have the extra training to treat OCD? Because it's not the degree that treats OCD, it's the person who's bothered to get the extra experience and the extra training, because that comes out of your pocket if you didn't get it in graduate school, which more often than not, therapists are not getting. In fact, a lot of times when I say this on social media, therapists will pipe in and they'll say, she's right. I didn't get any extra OCD training. I mean, so I know, because I am 25 years out of graduate school. That's really sad. It makes me feel really old. But yeah, I'm 25 years out of graduate school, not even just college, but graduate school. And so one may hope that things have changed, but not entirely, because I know there are some good programs out there, but for the most part, people are still leaving where they can put up a shingle and say they're a therapist, and they can say they treat OCD and not know at all what they're doing. And more scary than that is not know that they don't know what they're doing. That's the scariest part. So there are lots of degrees that allow somebody to be a therapist. And that doesn't matter. And so you can have a master's in counseling, you could be a licensed you could be a licensed professional counselor at LPC. It's like alphabet soup. You can have an LCSW, that's what I have, a licensed clinical social work. There are a ton of master's level programs and degrees that all allow you to be a therapist. You can also have your PsyD or your PhD and be a doctor. It doesn't matter, because if you haven't had the OCD training, it doesn't matter if you have a PhD or an MSW or an LPC. None of it matters, because just because you can do therapy doesn't mean you know what you're doing with OCD. Okay, I think you get my point. So look at their training, not necessarily their degree. If they have a degree and they're allowed to call themselves a therapist, check that box. Now, if you live in a place where people can call themselves coaches and they don't have to have a degree, that's something different. You're going to want to really investigate that, because that means they're not being supervised by like a board of behavioral health. And when you're a therapist, you have to take a test. You have to have gone to graduate school. You have to, have a license. Like, I don't even practice anymore, and I maintain my license because I want to stay on top of that. And I'm also one of those people who's like, who knows what's going to happen in my life? So I always maintain my license. I have an active license to practice, even though I closed my practice back in 2021 after my husband passed away. And so if somebody's calling themselves a therapist and they've gotten letters behind after their name and they've got a degree on the wall, that's good. It's a good sign that they've had the fundamental training. Then you have to ask them what kind of training they've had with OCD. And so that's what you want to focus on. When it comes to medication management, some people get confused about this too, which does surprise me, but then I forget, like, not everybody has lived in this world. I have a weird life story, because I literally grew up in mental health, not because anybody was a therapist, but because everybody saw a therapist. So I kind of learned this stuff like from the very beginning. My father had bipolar, which eventually turned into psychosis. And so literally I was in treatment centers visiting my dad. He was inpatient all the time for months and months at a time. I learned how to driving to a psychiatric hospital. When I was in college, my first year, I remember going to Columbia, where he was at a psychiatric hospital. Like, my whole childhood is marked by when my dad tried to kill himself and when he was in hospitals. And then I had a sibling who was also in treatment centers. And so this was where we spent a lot of my time growing up. So I knew the difference between a psychiatrist, a psychiatric nurse practitioner, and a therapist. But I'm realizing that most people didn't have a dysfunctional childhood. Well, that's not true. Many people don't, but a lot of people do. And so let's talk about the difference. A psychiatrist prescribes medication. If you go to see a psychiatrist, they're expecting that you're contemplating seeing them for medication. They're not doing therapy. Now, there are outliers. I mean, look, with everything else, you might find a fantastic psychiatrist and they happen to do therapy. That's not the norm. Normally, these are two separate categories. You get a therapist, which could be an LCSW, a PhD. It could be anybody, but they're all still your therapist providing therapy. And then you have a psychiatrist. And the psychiatrist prescribes the medication or consults with you on the possibility of taking medication. In the United States, and I don't know, it might be different in the UK and in Ireland and in Canada, the other big, and Australia, the big places where people listen to me as well. Though there are actually, I'm on the charts for a lot of other countries. And so that is not necessarily true, because I'm actually ranked really high in Denmark. Well, we won't go through my chart rankings, but it is fascinating to see. Like right now, I'm number 84 for Kids and Family Podcasts in Kuwait. And right behind that in Lithuania, and then Cyprus, and then Guatemala. So, and then Hungary, which actually are my people, because my dad was Hungarian. Now you know more about me than you ever wanted to know. So who knows where you're listening. So it might be different where you are, but in general, therapists and psychiatrists, no matter where you live, they have these separate roles. Now, there's also a psychiatric nurse practitioner, and they can also prescribe medication. I actually really like psychiatric nurse practitioners because this is just bias from my own experience. They spend a lot of time with me, and I don't feel like they're rushing me as much as the psychiatrists that I've worked with. And I'm talking about as a mom with my own kids. They do the exact same thing. Psychiatrists and psychiatric nurse practitioners, I have found, and again, this is just from my own experience, it may not be true for you, but I have found that psychiatric nurse practitioners tend to take my insurance. If you live in the United States, that really matters. If you are in the UK or Canada and you're dealing with like the CAMs, maybe it doesn't matter because you get what you get and you don't throw a fit, as we say in kindergarten. But I like in the United States, I like psychiatric nurse practitioners because they tend to take my insurance. They tend to spend a longer time with me and they tend to be more in tune. That has been the very short experience of my experience. I know I said experience twice and I tried not to, but I couldn't think of another word. So those are for medication. If your child stops taking medication or they don't need to take medication, then you don't see a psychiatrist or a psychiatric nurse practitioner because that's what they do. Some people get really confused. They'll say to me, Natasha, I went to go see a psychiatrist and all he wanted to do was prescribe medicine. And I'm like, yeah, that's what they do. Why did you go see them? So normally, if you're going to have a team, you are going to have a therapist and a psychiatrist. You don't have one or the other. If you're going to have medication and therapy, you're not going to find one person who typically does both. There might be that rainbow unicorn out there that is listening who's like, I do. You are fantastic, but that's not the norm. Okay. Then we want to look at what modalities are they going to be doing with your child. And so when we're talking about OCD, we want to find somebody who does cognitive behavioral therapy with, or as a subcategory, ERP. Now, ERP, exposure response prevention, is a type of cognitive behavioral therapy. Lots of people are CBT therapists, but not a lot of CBT therapists are ERP therapists. So it goes one way and not the other. So if somebody says, yeah, I do CBT, that's not a yes, I do ERP. In fact, most don't. So you have to ask, do you do ERP? And if they say ER what? Then you get your running shoes on, because if your child has OCD and they don't know what ERP is, they've just told you that they have no training in OCD. Because anyone who's had any training in OCD will know at least what ERP is. They may not do it because there are second line approaches that are coming up that are very popular, and there are different modalities. We're going to talk about that in a second, where they may know what ERP is, but maybe they don't practice it. Maybe they do other things. I am biased. I love ERP. I would say you want to find an ERP therapist first. I think that is a good place to start. But there are other approaches as well. So ACT, acceptance commitment therapy. I'm recording this late at night and I'm very tired. And we'll talk about why that is in a minute. Acceptance commitment therapy is a great supplement to ERP. And it could be a great starting point. If your child is resistant to doing exposures, or if you've tried ERP and it did not work, ACT is a great approach. And often ACT and ERP go in hand, and a really great skilled therapist where they are seeing that the child is not willing or able to do exposures can move into an ACT type of modality. The other thing that I would look at is family involvement. And so Ellie Leibowitz's SPACE program is a really good approach. So SPACE stands for Supportive Parenting for Anxious Childhood Emotions. And it is a parent-only approach of how to systematically pull back your enabling of anxiety and OCD. An OCD therapist who works with kids should be SPACE trained and should be able to do SPACE with you. That would be a really good indication that they're keeping up with the training, because you want a therapist who is growing and learning and keeping up with the training. Now, sometimes, a lot of the time, okay, honestly, most of the time, beggars can't be choosers. And I kind of feel like we're in that situation for a different reason. I'll tell you in a second, but beggars can't be choosers. And so you might have one person in your state who does child OCD therapy. And that's pretty much what you have to pick, because you don't have a lot of choice. But if you live in a metropolitan area, you might have a lot of choices. And if you can get picky, which most of us can't, but if you can, then you want to look for somebody who also has some space abilities, because that's a really helpful thing. Even if they don't have space training, they should work with a family. Family involvement with OCD is key. And if it's, a drop off and a pickup and no conversation, that's concerning, because it's like treating the arm without the other arm. Family is always involved with OCD, and family should be trained. Okay, we're going to take a quick break. And after the break, I want to talk about levels of care. This is where you might not know what I'm talking about. Stay tuned. We'll be right back. Welcome back. Okay, let's get into levels of care. So now you know that at the very least, you should have a therapist. And in an ideal world, they should be OCD trained. Honestly, if it was my child and my child had OCD and it was a choice between a therapist who didn't know what OCD was and didn't know how to treat it, or no therapy and me just doing it at home, I would pick doing it at home, because a therapist who has no skill or training in OCD can do more harm than good. And that is a concern. Both my kids actually had therapists who didn't have OCD training, but they were respectful and they were willing to only focus on other areas and not touch the OCD. And that made me feel comfortable, because I was like, okay, I could do the OCD part, but we had grief, right? They lost their dad. They had anxiety. My son has ARFID. Then he was diagnosed with ADHD and then ASD. So we got other things going on where we needed the support. But then eventually I shifted over. Well, PsyPact happened. And if you don't know what PsyPact is, let me look up the website for you. I will tell you what it is. Hold on. Doing it in real time, because that's how I'm rolling today. When COVID happened, PsyPact happened. And PsyPact is a reciprocity program where psychologists, and it's only for psychologists, but I actually saw that they are opening it up to other degrees. And so that might be changing. And I don't have a map for other degrees. And I can't remember what other degree it was, but it got me excited, because I thought, finally, they're going to open it up to other providers other than psychologists, because there's a lot of us out there that are not psychologists. There's so many master's programs. But if you go to psypact.gov, so that's PSYPACT.gov, if you live in the United States, this is just for the United States. And you can see the map there. Actually, if you go /page/PsyPact map, or you can just go to their main website and look for the menu that says PsyPact map, it will show you what states, it'll show you if your state is part of PsyPact, which almost all of them are. I mean, there are only a few that aren't. But the ones that aren't include Alaska, California, Guam, Iowa, Louisiana, New Mexico, Oregon, Puerto Rico, and U.S. Virgin Islands. I just saved you time. So you don't even have to go if you're in those states, because you are not in PsyPact right now. They might eventually, but they're not right now. So you can always circle back. But if I didn't name your state, that means that you are in PsyPact. And that means that you can go see a psychologist in any other state that is also in PsyPact. So that opened it up in COVID, where my kids in Arizona were able to see a therapist in Georgia. And that was a beautiful thing, because I had the whole country to look at and say, who's an expert in ARFID? Who's an expert in anxiety and OCD? Can I get a really good therapist? And I did for both my kids. And so that might help you as well. But let's talk about levels of care. So at a very basic level, you have outpatient. Outpatient therapy is once a week, maybe twice a week, but not normally. Sometimes every other week. If you get any further than that, you're kind of in maintenance mode. Therapy less than every other week is, unless you're just doing maintenance and you've already made a lot of progress, that's not going to move the dial. And so normally weekly or every other week. My daughter is every other week. My son was every week, but we'll talk about him in a second. So that's outpatient. That's what people call outpatient. And then moving up from there, we talk about a higher level of care, right? So that outpatient's the lowest. Then if they need a higher level of care, it means that their issues are acute enough that going once a week isn't going to make an impact. And so they need a higher level of care. And so sometimes you'll hear a therapist say, oh, I think she needs a higher level of care. or we'll have to look at a higher level of care. That's what they're talking about. The next level of care is intensive outpatient. And so that is called IOP, intensive outpatient program. And an IOP, this is the frustrating thing, is that even though there are the names for these things, they're not uniform across the board. And so you can't say this is what an IOP is, because it may look different in this program than it looks in this program. But the only common denominator with an IOP is the intensity. And so if you think about it, like these are like dosages of therapy. So outpatient's a low dose, intensive outpatient is a higher dose. And then we're going to get into higher doses after that, not of medication, but of therapy. And so intensive outpatient can look like 3 hours Monday through Friday. It can look like 3 therapy sessions, an hour a week. I've seen it look very different depending on the program. And so there's no uniform amount of time, but it's more intensive. And so normally it's at least, I don't want to put a cap on it, but it's normally quite a few hours a week. It might be multiple days. It might be just a couple of days. But that's what IOP is. And then they come home. From there, a higher level of care is partial hospitalization, or PHP, partial hospitalization program. That's more intense than the IOP. And so typically with a PHP, they are, the reason why it's called partial hospitalization is they're practically living at the treatment center, but they come home at night. And so for some people, that's like an 8-hour day in a program. And typically you're not like in a therapy office, you are in some sort of treatment program. And so a therapist doesn't typically do a PHP, although some people offer that. It's more common that a therapist might offer IOP. So I've seen, I think my daughter's therapist offers IOP. My son's therapist offered an IOP type of thing at one point where he got to see her multiple times a week. And I've worked with therapists. Actually, one of my friends and colleagues, I know she does intensive outpatient where somebody will fly in and see her and she'll do like a really intensive for a week or two and just be like meet with them every single day. So IOP can look really different for different people. It could be a regular therapist. It could be a program. Normally when you're talking about partial hospitalization program, you're talking about a treatment program and they're there all day, typically Monday through Friday, but some could be even longer. And then they come home at night. And so that's almost like a residential treatment center, but they're coming home. I already spoiled the next one. So the higher level of from PHP is RTC, which is a residential treatment center. And so at an RTC, that is a treatment center where people live. And there are treatment centers for children. There are treatment centers for adolescents. There are treatment centers for adults. And so they would go and they would live there because they need to be immersed in treatment. They need to be there 24/7 so that people can monitor them, monitor their medication, give them therapy, really do intensive treatment with them so they can move the dial. There are a lot of people who go to RTC and it's a life changer because it just catapults their progress because they're having this intense environment surrounded by therapeutic intervention and other peers who also have similar struggles. But that's a hard one because it's hard to get our kids to go there. It's hard to say, I'm going to send my kid there. There's a lot of things that come with that. But if you go to the right one, it can really make a big difference. And the last and highest level of care is inpatient hospitalization. And so when you go to a hospital, typically, and again, this is, I'm speaking in broad strokes. There could be nuances where maybe this is true where you live, especially for those of you that live outside of the United States, it might be different. But inpatient hospitalization is typically like a triage because you are a danger to yourself or you're a danger to other people. And normally people are hospitalized for short periods of time. Like my dad was hospitalized a lot. It'd be like a 7 to 10 day stay. And then they'd move him to a residential treatment center where he would be there for months. Normally, hospitalization is just to stabilize you, get medication, and make sure you're not a danger to yourself or other people. That's typically what it is. There might be exceptions to that, but that's what it looks like. And so knowing all of that, it helps you understand where you're at and what options you have. Because sometimes people are like, if therapy doesn't work, I don't know what I'll do. And it's like, well, there's a lot of wiggle room. There's IOP, there's PHP, there's RTC. I mean, inpatient hospitalization is never something that we want to aspire to, but there are lots of different levels of care to make sure that your kids get the help they need. But it is really scary. And I know this because we just started a PHP today. Well, we didn't, my son did. And it's nerve wracking when you're starting those things because you just don't know if it's going to move the dial. So for OCD, there are some really good go-to OCD treatment centers that I feel really comfortable recommending. There are a lot of them, but the ones that I know personally, I know people who've worked there, I have been to some of them, is Rogers Memorial Hospital. Now they say hospital, but they do outpatient, they do IOP, they do partial hospitalization, and they do RTC. So don't let the name fool you, but Rogers Memorial Hospital, they have locations all over the country. Their main one is in Wisconsin. They have some in Philadelphia, Florida, San Diego. I know there's a whole bunch more. They just keep opening up more, but those are the main ones that I know of. But you can go to their website and find out, and they have different programs. They have adolescent programs. They have adult programs. And I would always send my kids to Rogers because to me, they are the creme de la creme of OCD treatment. Then you have got McLean, which is also really great. A lot of great people come out of McLean, and that is in Boston. And then you have OCD Institute of Texas, which is in Houston, and that's phenomenal as well. Those are the three that I tend to recommend because I trust them. And I have heard so many people go to them. I've sent clients there and they've done well. And so those are solid. What's tricky for us is really OCD isn't our primary issue right now. It's the RFID. And the OCD we can handle. In fact, I would have to say, like my son, I don't really see OCD in him right now. I see RFID as his number one problem. ASD is there, but that's just complicating the RFID and the anxiety and the ADHD. And so we've got all of that. And I know a lot of you out there have similar things going on, and diagnosed with PANS a long time ago. But then when I try to go back to the PANS clinic, they're like, oh, it doesn't sound like he has PANS anymore. Didn't even do any blood work or check. Just said, no, he just needs treatment. So RFID treatment's really hard. And when you're looking for a higher level of care, I was so grateful that I have my experience. I was like, this kid's so lucky. He has no idea, because I knew I've worked in treatment centers. I know what to ask for that I think the average parent wouldn't know to ask, because I'm not going to send my child with RFID to a PHP program or even an IOP program where there are kids that aren't dealing with similar issues. Because a lot of times our anxious kids and our kids with OCD, they tend to be the kids that get picked on if they're in an RTC program with other kids who have other issues like oppositional defiance disorder or bipolar. I want my child to be in a program that's going to really be concentrated on their issue. So if you're looking for a higher level of care, like an IOP or a PHP, and you can't go to Rogers, McLean, or OCD Institute of Texas, because those would be my preference. And a lot of times you can't, like I can't pick up and move and go to any of those locations. I'm pretty sure Rogers has an RFID program. I'm not sure if it's inpatient, but it's not an option anyway, because I'm a widow and I've got a 14-year-old that I have to raise, and I'm not going to displace her, and I'm not going to leave him in another state because I would feel bad. I feel like I'd have to be there. He's like be too fragile. So that, and OCD is not his primary issue. And so it's RFID, which makes it really tricky. And I know a lot of people have a hard time because they need to find a higher level of care. They can't go to those different programs I talked about. And a lot of other programs will say that they treat OCD. Or in our case, a lot of programs will say they treat ARFID. And question mark, do they? I don't know. We're kind of in the middle of it, actually. So these are the questions I would recommend asking if you're not going to those 3 programs that I already mentioned. Ask them, how many kids have anxiety or OCD? When I was looking for ARFID, I asked them, how many kids do you treat in here that have ARFID? I went to one PHP program, and they're actually really well known, and they're really well known for eating disorders. And so, at least when I was a therapist, I mean, I remember this was the place that you sent anybody with an eating disorder. And on their website, of course, they're like, we absolutely treat ARFID. Of course, we treat ARFID. And so I was like, I'm just going to go there and do a tour just to make sure and ask them these questions. And I asked them how many people in here have ARFID, and the answer was none. So that was concerning. And then I asked, are there going to be a mix of kids with various issues? And I'm looking for kids that aren't going to, I don't want my child to go in for ARFID and come out with self-harming behavior or come out being bullied. And in some programs, not all of them, but I've worked in treatment centers, and there's a pecking order, especially when you're mixing a whole bunch of different diagnoses. It can get really concerning. And so, and this is just my opinion. I mean, you might have been in programs where it was a really good thing and it was really helpful. This is just my own personal experience, because I can hear you out there being like, well, that's not true. Or I work at a program that's okay. It's just my personal experience. And I worked in a treatment center, and that was my experience at that treatment center.
It's time we put help directly in our kids' hands. Introducing Crushing OCD course for kids and teens.
It was way more helpful than all the other therapy we've ever done, because we didn't really know what to do. So we weren't really doing it before. So the course helped to figure out what the exposures are and how to do them.
We're not in therapy and find it really hard to find an ERP trained therapist here. So we're currently with like the public health service, but again, they don't seem to be trained in ERP. It's filled that gap that we don't have that was desperately needed.
This was really well timed for us to use between therapists and to help us get off to a good start with this new practice.
It was easy to use. I was able to do it from my phone or also on the computer.
There's different ages, so there were younger kids, there were teenagers, and so that was really nice too, to have a variety of ages where it wasn't just geared towards younger kids or older kids. It was a nice variety.
It's helpful for our kids to hear it from this third party as opposed to just us saying it.
I really like the offense and defense method. I love working on poking at OCD while it's sleeping. It makes it a little bit easier to do, and it's kind of fun. I'm planning on using it to work on my fear of holding or touching batteries and stuff like that.
So it was really helpful, and I think a lot of other kids would like it. I thought that I was the only one who had worrying about the weather and stuff. And then there was somebody else on there who worried about the same thing, which was really helpful.
Seems less scary to work on stuff now that I've watched this class, and I'm more interested to work on it.
I like trying to do more exposures still, and before I wasn't, I just didn't want to do them.
I've worked on some of my bigger compulsions and been successful.
I realized that it was helpful to do the exposures. Before it was really, really hard. It's still hard, but it's helpful to know that I need to do them.
Before there would be a lot of battles about it, so it is definitely less loggerheads.
Really, really good course and super helpful.
Definitely would recommend this. It's really easy to follow. It's nice bite-sized videos. I really like the worksheets that go along with it, and I think it's really helpful.
To learn more about this course and register your child or teen, go to atparentingsurvivalschool.com.
I want my child to be in as concentrated of a program as possible. So if I'm going in there for OCD, I want it to be predominantly OCD. If it's anxiety and OCD, I want it to be predominantly anxiety and OCD. If it's an ARFID program, ideally I wanted it to just be ARFID, but we'll get to that. The next issue is I ask how many kids in here will have drug issues. How many of them have suicidal ideation or homicidal ideation? I'm getting a pulse on the severity of various issues that I kind of don't want my child to be exposed to if they're not dealing with it. If my child has drug issues or they have suicidal ideation, then that would be a positive because they're going to be around other people and they're going to be around staff who know how to handle it. I want to know, how often do they do therapy? Don't assume they do programming the whole time. They don't. And so this often throws parents for a loop. When I worked at a treatment center, it was a locked level 1 treatment center, and I was the therapist, and I did therapy with kids once a week. They were there 24/7, and they got therapy 1 hour a week. The rest of the time was just behavioral management, med management, and frankly, a lot of abuse. It was just a really bad place to work. But that's not all places. You just have to do your homework because there are good and there are bad places. So I asked those questions. I also asked, and the answer I got for the other place that I was looking at was, I believe it was once a week. I don't even know if it was once a week. Maybe it was once a week. The other questions I ask are, do kids run away? That tells me a lot about what's going on in the program and the type of kids that are going there. Do they need to be restrained? That tells me a lot about the volatility of the program. How out of control does this environment get? Now, having said that, some kids need that. Some kids are that. They have drug problems. They have suicidal ideation. They get aggressive. They get violent. They need a program that can accommodate that. For my child, they don't have those issues, and I don't want them to be around those issues because that will be traumatizing. So I want to know before I go. So I got a bunch of bad answers to all those questions, and my child never saw the inside of that treatment program. And they would have if I didn't know all the right questions to ask, because on paper, they looked really good. Now, what we did wind up doing is that place actually referred me to the current place that I'm at. And so it served a purpose. I always like to look at life like that. Like, it's a windy road, and sometimes to get to your destination, you have to go the long way. And that really helps me put perspective in my life. And this was just a windy road. And they referred me to this other program. And that's where we started today. But I did ask, I said, how many kids do you have who have ARFID in here? And I didn't really like the answer, to be honest. First of all, they were like, we can't tell you that due to confidentiality. And I was like, that's kind of a lame answer, because you could give me a percentage. You could say, well, 20% do. Or you could say, well, we have 7 kids and 2 have ARFID. To me, that was an answer of, you don't have any kids with ARFID and you don't want to tell me that. That's fine. But we're only on day 1, so I'll keep you posted. But I've got a motivated child. And this is the other thing I want to mention before we wrap up, is it irks me, no offense, to hear parents complain about how much they have to drive. They'll be like, well, the person that you referred me to is like 45 minutes away. Do you have anybody closer? And I'm like, do you know how lucky you are to have an child OCD therapist 45 minutes from you? That's gold. People would die for that. When I was a therapist, I'm still a therapist, but when I had a practice, I had people driving across state lines to see me because I wasn't licensed in other states. They would literally drive to Arizona to have sessions with me. I had multiple families doing that from California and New Mexico. Why? Because it's so hard to find an OCD trained therapist. So if you have to drive 45 minutes, that's a gift. I know life is really rough and nobody wants to be driving all the time, but you're going to have to drive for good treatment. We are driving. Now, we're only on day 1. It takes me an hour to get there, and then I have to drive an hour back. And then I have to go pick him up. That's an hour back to go get him, and it's an hour back. That's 4 hours. And today, they were like, yeah, we're thinking this is probably going to be a 24-week situation. I'm like, 24 weeks? How long is that? How many months is that? Well, it's 6 months. I did the math. I'm like, oh my gosh, this is going to be a half a year. I did hyperventilate a little bit today. I started feeling really overwhelmed. But then I was like, you know what? This is a gift. Insurance covers it. I have a willing child right now. It's day 1. That may change. It didn't go well today. And so I'm really hoping that it goes well tomorrow. I'm really hoping they know how to treat ARFID, because that's kind of concerning me. but I'll keep you posted. But all that to say, that is the journey of levels of care. So now you know everything about what you want to look for in a therapist, the difference between a psychiatrist, psychiatric nurse practitioner, and a therapist, and the higher levels of care that are there for you. I've always known they're there for me. I never thought that we'd need to tap into it. But you know what? It feels good to know that there are options. And even from PHP, there's an option to residential treatment. I don't want that for him, even though he really needs a higher level of care. But I know it's there if he really needs it and if he's willing to go. And that's the other part, is that most of these programs they have to have their willingness to participate. So they have to be willing. They can't be forced to go to most anxiety and OCD treatment programs. There are other programs, other behavioral programs where it doesn't matter whether they want to go or not. They don't have a choice. But typically with OCD, I think with Rogers, I don't know about McLean, I'm pretty sure, and OCD Institute of Texas, you have to be a willing participant in treatment, which makes sense because it's not like they have magic fairy dust. They're going to sprinkle on you and boom, you're going to be done. You have to have a willing person to be able to do exposures and participate in therapy. Same thing with ARFID. Like, if you're not going to eat, you're not going to eat. Like, they can't force you to eat. They could G-tube you, but that's it. And so it has to be a willing situation, which makes it tricky for some of you. So I'm counting my blessings. I'm like, yeah, I have to drive 4 hours each day. But after I got really, really overwhelmed today and I was in Pilates and my brain wasn't stopping and I was like, I have no time for anything and I'm so overwhelmed. I was like, look, this is a gift. So many people would die for this gift of insurance covered treatment in your state and a willing kid right now. I say right now, because I mean, I could be talking to you in 3 days and things could go south really fast. But for today, and that's all I care about because I like to be in the moment, I have gratitude. I'm going to bed with gratitude. I'm really tired because I'm recording a podcast at 8:45 p.m. because I had no time today because I'm driving all day long. But it'll be worth it if it works, and it'll be worth it if it makes any improvement because I have a child who's willing to do it. Well, I hope that you found this helpful. I hope that you find my podcast helpful in general. If you are, don't forget to hit a star, write a review. I greatly appreciate it. I appreciate you. And don't forget to find the sparkle in everything you do. Even today when I was overwhelmed, the thing that helped me the most was to ground myself and say, look, where's the sparkle? I have a willing kid. Sparkle. Insurance. Sparkle, sparkle. In my state. Sparkle. People willing to treat him. Sparkle, sparkle. There's sparkles in your life too. Go find them. It doesn't mean that we're like not validating the struggle, but there are always a glimmer. There's some glimmers out there too, little shimmers. All right, I'll talk to you next Tuesday.
Thank you for listening to the AT Parenting Survival Podcast. To get additional support raising a child with anxiety or OCD, visit Natasha's online school of on-demand classes at atparentingsurvivalschool.com.